Hi, everyone. I've been talking a lot today, so I apologize for that. I'm Christine Lovely, so I'm going to give a very quick introduction again. I am not going to show you slides, and I'm going to tell you why in a minute. So just a quick recap, I am a medical oncologist, so I treat lung cancer. I'm also a cancer researcher, so I have a lung cancer lab as well where we study small cell as well, thinking about immunology of small cell and liquid biopsies. I am not going to talk about any of that today. I would love to talk to you about it, but I am specifically not going to show you slides and talk about my research today. Why? Okay, big reason. First, we've been hearing amazing lectures all day from my amazing colleagues, and they're awesome. And so we're going to have a little bit of a break from lecture for a while, and we're going to have a chat, and that's why it's called Fireside Chat. We don't really have fire, but this is going to be super duper informal. And why are we going to do something super informal? Here's why. Number one, everyone's brain needs a little bit of a break right now from all the great talks we've heard. And number two is a lot of times you come to these meetings, and I'm sure you've all been to meetings before. I've been to a lot of them. And sometimes there's not really a chance to sort of decompress, which means you've heard a lot of information, and you're like, what are they talking about? And the question and answer session tends to get so rushed, and you're like, God, I wish I could have asked this, or I want to ask a question, but I'm sort of scared to ask. And I'm here to say any questions are on the table for our time. Now, I cannot provide direct medical advice because that's a little bit out of bounds, but what I can do is say, we can talk about anything. We can talk about biomarkers, we can talk about mice, we can talk about clinical stuff, we can talk about how do you take care of somebody with small cell, we can talk about blood tests, we can talk about really practical things. We can go the whole gamut from what do you do when you see your doctor in clinic to what does a research lab look like? Because my world sort of spans both of those realms. And again, the whole spirit of this is let's be super informal. We started out this day with, hey, we're family here, and so what do families do? They talk. Sometimes they yell at each other, at least my family does. I'm sure everyone has that experience with their family. You sort of love them and you hate them at the same time, and we love and hate lung cancer, right? Lung cancer is what brought us together today, but we love to hate it together. And so we're going to love to hate it together. And in that vein, what I want to also start by saying is the majority of people with small cell lung cancer do not get to come to forums like this. So it is the vast minority of people with small cell lung cancer who get to attend a meeting like this. And so maybe let's have a moment of silence to remember everyone with small cell lung cancer who is not with us today, those who we know, those our friends, our colleagues, our own patients, the patients we've never met, the faces we've never seen, the people who contributed to all the studies, the people who did not contribute to this. It doesn't matter. Let's take a moment and remember them in silence. Thank you all for that moment of silence. And I would say, please keep all those patients whose faces you do not see in your mind and in your hearts throughout today, tomorrow, and the rest of the days, because that will continue to be our passion. And so let's jump in, and don't be shy, and I can walk around the room, and I can even start with questions, and we can talk about things that have already come up, we can talk about things that have not come up. There is no script here on purpose. This is the time to decompress from the lectures that you've heard. There's been a lot of information. We can even do things like, Christine, what exactly is a biomarker? Christine, what does ASCL1 stand for? Christine, how do you get into a clinical trial? What does that even mean? What is phase 1? What is phase 2? How do I even find that? There is nothing too simple. Okay, here we go. I love a volunteer.
I don't really have a question. I just wanted to get in before Maida started talking. No, that's not true. She can hit me from there. Can you describe what BITE technology is, how it works? Can you?
Okay. So BITE technology, bispecific T-cell engineering technology. So Dr. Sands And you've probably recognized this in our discussions today. We all know each other pretty well because we travel in the same circles, right? So a bite therapy is a therapy that is not chemo. Sorry, I'm going to get out of the way. I don't mean to be too close. Sorry about that. Is basically a cool new therapy where the idea is you capture a marker on the tumor cell with one sort of arm of the therapy and an immune cell with the other arm. So kind of like bringing the immune cell to the tumor. That's the idea. So it's an idea, and this goes back to something that's been mentioned in many of the talks, and Trudy mentioned this in hers, is how do you, the best drug that we have, well, actually, I'm going to hark on several of the points. So Dr. Sands said the best way to treat cancer is to not get it in the first place. And so screening. But that's not going to solve every case. Let's remember, outside of lung cancer in general, 1 in 2 men and 1 in 3 women in the United States will have some form of cancer. Holy cow. So we're talking about small cell lung cancer. That's one piece of the pie. But this is something that touches every single person's life in this room. Wow. Okay. So the best form of cancer is to not have it, but that's an idealistic case, right? We're never going to have that completely. The second thing is, once you have it, can you use the power of your own body to get rid of it? And how do you do that? So you may say, well, Christine, if I get COVID, if I get pneumonia, if I get chicken pox, you have it, you get some kind of illness from it, and your body eradicates it. Your immune system takes care of it. So why doesn't my immune system take care of the cancer? Well, that's literally the $1 trillion question, right? Why doesn't your immune system just get rid of the cancer? It's not supposed to be there. And there are some patients who do. Their immune system does get rid of the cancer. And so when Traparna shows you the tail of this curve, why do we get excited about the, quote, tail of this curve that we call, the fancy name is the Kaplan-Meier curve? Those are the patients who get immunotherapy, and for whatever reason that we don't understand, their immune systems get rid of the cancer or keep it at bay for long term. But that's only the minority of patients. And so with our current forms of immunotherapy for lung cancer, which are drugs that we call LiveLung and PD-L1 immune. Oops. I broke it. There it is. Okay. So the current forms of immunotherapy, drugs that target checkpoint inhibitors called PD-1 and PD-L1, they only work for the minority of patients. BiTE therapy is a new way to target the immune system by saying, if you don't have the immune cells in your tumor, in the neighborhood of the tumor, can we bring them there? By capturing an immune cell like a T cell and bringing it to where the tumor cell is. Force that pair, force the immune cell to come to the tumor cell. That's how a BiTE therapy works. Yes? Okay, so the question is, what is a biomarker? Thank you so much for asking, okay? And again, I'm going to reiterate, yes, thank you. That's exactly why we're having this fireside chat, because you probably all have realized this now, and we're guilty of this, very much so. There is a language of medicine. There is a language of science. There's some overlap of those two languages, but sometimes in clinic, especially in clinic, you sit with your doctor and it's like 10, 15 minutes and all these words get thrown at you and you're like, what are you talking about? And it is like a vocabulary that feels overwhelming, and all these big names and drugs and side effects, and it's completely overwhelming. So I'm going to answer your question, but I'm also going to say, and I think this is really important, and probably most of everyone in this room, because you're already advocates for yourself by virtue of being here, but please spread this word to your family members, whether they have cancer or not, whatever medical problem they have. You know, when you're sitting in front of a doctor's office, I even do this when I go to my own doctors, please take notes, because you know what happens. It goes by in a snap, and you're like, I don't remember what they said. Bring somebody with you, take notes, because do something, because it just the time that you have in front of your doctor is so short, and everybody wants to help you, but you're going to leave having more questions than you started with. So, what is a biomarker? A biomarker is a way to select when a drug will work or not work, and it works in both directions. And so, there are at your table, I'm counting, 7 people. And so, if everybody at this table had a tumor, then we want to test the tumor and say, hey, is there a biomarker for drug A? And drug A may not work against everyone's tumor. So when we want to figure out whose tumor drug A is going to work for, we have a marker on the tumor cell that says, drug A works for your tumor, but not everybody else's. It's a selection tool. It's a way to figure out in the world of lung cancer or other cancers, when is a drug going to work or when is it not going to work? So when we say biomarker in the cancer realm, and there's other uses for biomarkers as well, but in the cancer realm, we're overwhelmingly think about a marker, some way to tell when a drug is going to work, but also when a drug is not going to work. And both of those are equally important. We tend to think about the positive. A biomarker is going to tell me when a drug is going to work, but biomarkers can also tell you when a drug is not going to work. And we can test for these biomarkers on tumors. We can sometimes test for them in blood. But it is a way for us to stack the deck in our favors to say, instead of just making a guess, we're making an educated guess to try to say, I'm going to make treatments based on information that's specific for that patient to say, I'm going to give you the best treatment possible based on understanding the characteristics being the biomarkers of your tumor. Yes? Can we get the mic? Oh, I'm sorry, I missed your microphone. I'm so sorry.
Go on, let her go. It's fine.
Okay.
I don't really need a microphone. I'm sorry. So my question is, do they automatically check our tumors for a biomarker, like my tumor is stored somewhere?
No. So herein comes the nuances. So for some types of cancer, automatically yes. Let's contrast with, I think Traparna used the analogy, the cousin, the non-small cell lung cancer. For non-small cell lung cancer, the more common type of lung cancer, 100% biomarker testing is standard of care. And so if I see, let's say I have clinic coming up, and I see patients, and I have 10 patients in clinic, and 8 of them have non-small cell lung cancer and 2 have small cell, roughly the percentage of non-small cell to small cell. Patients with non-small cell lung cancer are reflexively going to have this, quote, biomarker testing based on what type of non-small cell lung cancer they have. It's even more nuanced than that. Because for non-small cell, there's something called adenocarcinoma, there's something called squamous, based on what it looks like under the microscope. And so that biomarker testing is really very specific to what kind of cancer a patient has. So the biomarkers for non-small cell lung cancer are different than biomarkers for bladder cancer, are different than the biomarkers for breast cancer, are different than the biomarkers for acute leukemia, different than the biomarkers for chronic leukemia. It's all different. So there is not a one-size-fits-all approach to biomarkers for cancer. In the public, we tend to think about cancer as sort of one thing. The truth is, it is extremely, 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 unbelievably nuanced. And that's a beauty and a curse. The beauty is it should be nuanced because they are very, 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 very different diseases. The curse is it becomes hard to keep up with it, but biomarkers depend on what type of cancer you have. Not all cancers have standard of care biomarkers. So in April 2024, it is not standard of care to have biomarker testing for small cell lung cancer because none of the therapies we use at present are biomarker driven, meaning the medicines we heard that we talked about today do not require a biomarker test in order to prescribe those medicines.
2 questions. Is it normal not to have any biomarkers? I mean, is that possible for a small cell lung cancer to have no biomarkers?
So it's not really that small cell doesn't have any biomarkers. It's that they haven't sort of worked their way into the treatment patterns yet. And so there actually are a lot of biomarkers for small cell. They just haven't evolved from the lab research realm into standard clinical care yet. And part of that is because it takes time to study a tumor, in this case small cell, and then evolve those studies into what becomes the standard practice, whether you're in North Carolina or Tennessee, where I'm from, or New York or Houston, Texas, or Alaska. Things have to kind of percolate and trickle through a series of testing before they become FDA approved, before they become the standard, before they become part of clinical guideline care. And so kind of the research that we're talking about, and we all love research because that's how we move paradigms into the clinic, but it has to be rigorously tested before it can get to be deployed to everyone everywhere. So yes, there are lots of biomarkers for small cell, but none of them have moved yet fully into the clinic to be part of standard clinical care. It'll get there, it's just not here yet.
The second question, so I'm on the trial and I go every 2 weeks. How long does that chemical or immunotherapy stay in my system that y'all can say, okay, not every 2 weeks? How long does it take to get out of your system, or does it always stay in there?
Yeah, so good question. And the question is, I'm going to zoom out and answer broadly for different types of drugs. So every drug has different parameters for how long it stays in the body. And different drugs stay in different people's bodies for different amounts of time. So it's partly the drug itself, and it's partly the patient. Because there's patient-specific factors that are going to influence how a drug is metabolized in your body as well. Your kidney function, your liver function, those affect how a drug stays in your body. Different therapies, like pill-based therapies, may stay in shorter than antibody therapies, like the checkpoint drugs we were talking about. These immunotherapies are antibodies. It can go anywhere from days to months. So even drugs, some of the drugs that are dosed every 3 weeks, some of those drugs can stay in your system for months, even though they're technically dosed every 3 weeks. As part of clinical trials, especially early phase clinical trials, the trials that we call phase 1 clinical trials, there's actually components of those trials where they do what's called PK/PD, pharmacokinetics and pharmacodynamics. That's just a fancy word to say they try to understand how the drug is distributed in different patients, how it goes through your whole circulation, how it's metabolized through your kidneys, through your liver, and how long it stays in your body. But just as before, as we were talking about, and this comes back to another important point actually, we were talking about the importance of diversity and making sure we have representation. Another really important point there is because different drugs are metabolized differently in different people. And so it's not just how does the drug work against the tumor, it's some of the side effects of drugs are different in different people because of the way that different drugs act. It's not just the drug in the tumor, it's the drug and the tumor and the person.
Dr. Lovely, I'd like to ask you about the financial impact of small cell lung cancer in particular, but particularly as it relates to entering a clinical trial, because oftentimes these patients have lost their job due to the disease and or the treatments, and and potentially their health insurance as well. And in the lung cancer space, there is not a lot of financial support, even to the point of paying for your parking or covering lunch for a patient to enter a clinical trial and make multiple trips to the. And I mean, there was a patient who you probably knew, everyone in the lung cancer space knew Linnea Olson, and she was passionate about trying to get clinical trials to change so that they would consider the financial impact to the patient and at least cover some of these things. Other trials do cover them, but could you just address that and how we as advocates might be able to influence change?
Sure. I'm going to address that from two angles, actually. Clinical just maybe a standard of care, because I think issue than just clinical trials. So let's start with the clinical trials first. To be frank, clinical trials are a business. And so, in my strong opinion, there should be compensation for the patient. Things like gas money and meals and patients, especially as the trials get more and more complicated in terms of the demands on the patient for what's expected to be done, often multiple blood draws, multiple scans, multiple times coming back and forth to clinic, which is helpful because that means we're learning about the drug, but it's time away from your family, from your loved ones, from your job, from everything. And so I think the onus is on advocates, the onus is on physicians, as people, helping to write the trials to say, what is the return on the investment to the patient? Benevolence is great. We all want to help the next generation, but also how are we going to make it practical for the person sitting in front of us to actually participate in this study? That is incredibly important. And remembering that, and the other side of the equation is, a company, frankly, is trying to bring a drug to market, and we want to help enroll by making it as easy as possible for the patient to actually participate in the study. We don't want patients to drop out midway through a study because they just simply can't afford the gas to come to participate in the trial. But I think there's a bigger issue here as well, and I think we can advocate for trying to get pharmaceutical companies to help pay like gas cards, hotel stays when they have to stay like an 8-10 hour day for blood draws, et cetera. I almost feel like that's an easier lift in some ways. But the harder thing I see, and I will say in my practice quite a lot. So I'm from Nashville, and I practice in an area where a lot of my patients drive like 3 or 4 hours to come to clinic to see me. Forgive me for using a bad word, but that sucks. Thank you. Thank you. I could use worse, but I'll hold back. My mom would be really ashamed of me if I used a worse word than that. That sucks. I mean, to drive 3 or 4 hours for like a 20-minute clinic visit, and you have to be there at 8:30 in the morning, so you're getting up at 3:30. I mean, we need a lot more care in the community. We need quality care in the community. So the care that you can get at big universities has to be care that you can get wherever you are, so that you can't just get state-of-the-art care at big centers wherever you're at, that you can get state-of-the-art care like tarlatamab. This is going to be a big deal when tarlatamab is approved, and it's amazing. I mean, to me, I don't mean to sound biased either, but like this is going to rock the world of small cell lung cancer. Holy cow. I mean, talk about an advance we've been looking forward to for a long time. Wow. I mean, the responses that are being seen in patients who have multiple lines of therapy, incredible. Like, incredible. This is something we've been waiting for a long amount of time. Here's our challenge now. How in the world are we going to get this to people? Let's think about that for a second. It requires hospitalizations, intense monitoring. It's only been done in major academic medical centers, and now we're going to be available to everyone everywhere, and we should demand that everybody everywhere be able to get it. How are we going to do that? I don't know. So, and money is going to solve some of the problems, but it won't solve them all, because we can't be expecting patients to be, their whole life revolving around their cancer. Cancer should be part of your life, but not your entire life. But let's be honest, anyone who's gone through cancer treatment, going through cancer treatment, a caretaker of somebody with cancer, that becomes the focal point of your whole life. And part of, I think, and this is my perspective as a physician, but also as somebody whose both parents are going through cancer treatment right now, and thank God they're doing well because I don't live with them and I can trust their healthcare provider, is like, you can't have everything else go on pause in your life. That's just not practical. So you have to sort of figure out how you're going to live your life and deal with this all at the same time. And so the financial implications of this and the life costs of having cancer are enormous, enormous. Sorry, Dusty, that was a lot longer answer to your question than you had wanted. But something I feel very strongly about, because I think to get healthcare equity, or whatever you want to call it, whatever we want to call it, to deliver the best care to everyone where they're at, and not always be expecting that people are going to be showing up at big medical centers in the big cities. That's just not practical. Okay.
So
I'm going to switch positions too. I'm going to go back here for a little while.
we've talked a lot today in this conference about the advances of the medical treatment and clinical trials. What about the mental side of this? How do we address that constant fear of dying, the scary part of this, what's the best avenue for us to take? And I know for myself, this community has definitely helped me. But what in the clinical setting, how is it being addressed?
Yeah, this is a great question, and okay, you want to answer? Go.
All the way back in 2009, I was diagnosed with a very rare orphan cancer. I was told I was going to die. I had an inoperable tumor. It's incurable. Thank God it's now treatable with a drug called Gleevec. But when I was first told that I was going to have to go on hospice care, I spent the whole afternoon crying. And I had somebody say, "You've got to stop crying and keep yourself positive, or you're just going to die from this." And I sat there for a minute and I said, I just got told I'm going to die. I just got told that everything I planned for my future is gone. And right now I am being positive. I'm very positive that I need to cry. And I think being true to ourselves, and there's a book that I was told to get, and it's called The Human Side of Cancer, and it's by Jamie Holland. And one of the chapters in there is called The Tyranny of Positive Thinking. And to me, excuse me for using a bad word, that's just bullshit, because that puts the onus for recurrence on the patient and not being positive. And that's not true. We've learned today on the cellular level that it's a crapshoot. And it has nothing to do with our mental attitude. Mental attitude will keep you going when you don't think you can, but it has nothing to do with recurrence. So just love yourself and be true to yourself. And if you gotta cry, cry. There, I'll get off my soapbox.
I love that answer. Beautiful.
Thank you, I've been there.
Yes.
I'm newbie to this word, so I have very fundamental, elementary questions. Because most of the patients with lung cancer is a non-small cell lung cancer, and then we have small cell lung cancer here. How do you determine which patients are small cell, which patients are non-small cell?
Yes. So thank you for the question. Again, please, everyone, I'm going to say this and I can't say it enough. There is no such thing as too naive a question right now, or a question like, this is the time, ask your questions, I promise. So how do I know if I'm just seeing lung cancer in general? So none of us work alone. So there's a team of people. You may see, for example, my face in clinic, and I will always smile at you when I see you, promise. But I work with a group of doctors, and some of those doctors are doctors that you will never see, and one of those doctors is a pathologist. And those are the doctors that look at the tumor under the microscope, and they're the ones who say, this looks like non-small cell lung cancer, or this looks like small cell lung cancer. And they're doing that from a biopsy. So the biopsy specimen that all patients with cancer get is sent to a group of doctors called pathologists. The pathologists are the doctors who look at it under the microscope, and they classify the type of tumor. They then report that back to people like me who are patient-facing, who then say, okay, this is the type of cancer you have, and here's how we're going to treat it.
Do all the patients get a biopsy, or not all the patients gets that?
So it is exceedingly uncommon. I can think of one instance in cancer where a biopsy is not required. But that is a very, 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 very specific case of liver cancer. We're not going to go there right now because it's very, very nuanced. But 99.9999999% of the time, you need a biopsy. Because not every spot is lung cancer. And so we can't fight a battle with an enemy that we don't know. And I don't mean to make too many trite, battle comparisons, but you have to know what you're facing. And the biopsy is actually telling you, this is what you're dealing with. And without that information, you're shooting in the dark. And so the biopsy tells you this is the type of cancer. And in the lungs, and I was just on tumor board, literally, we have, as most places do, once a week we have a big group, a meeting, we call it thoracic tumor board, where it's medical oncologists like myself, radiation oncologists, thoracic surgeons, pulmonologists, and pathologists, and we present cases, and we talk about challenging cases. And in these groups, then we'd say, not everything in the lungs is cancer. And so one of the cases that was just presented just an hour ago was a patient who they biopsied a lesion, and it wasn't lung cancer. And so you can't just see something on a scan and assume that it's cancer. It has to be biopsied and looked at microscopically, and those microscopic features will help us as physicians to determine what's the best course for the patient.
I'd like to make a comment there to your question. So there is another form of lung cancer which actually develops from non-small cell. So we have seen now that non-small cell cancer patients who have undergone tyrosine kinase inhibitor treatments, they often develop, 15% of them develop small cell lung cancer during the course of their treatment as a response, as a mechanism of drug resistance. So even if you have been initially, and there are many genetic alterations that sort of inform you about the risk of having these transformed small cell tumors. So even if you have been diagnosed with non-small cell, let's say you have an EGFR mutation, and in your NJS testing, you have a P53 and RB1 loss, and then you go on osimertinib, if and when you develop resistance, when you come back, the doctor will most likely do another repeat biopsy on you, and then they can detect small cell. So small cell de novo is what we have discussed so far, but there is another form that develops from non-small cell. So that kind of highlights the importance of a repeat biopsy, even for patients with non-small cell lung cancer with certain genetic alterations.
Can I go back to my friend Wendy and her question about dealing with this fear of dying? I think every one of us have gone through that fear if we're not still going through it. I was fairly certain I was going to be dead too. So, and that was, almost 6 years ago. One day during treatments, I was we had private rooms at Kellogg Cancer Center, which was kind of amazing. And I sent my husband out of the room, and I just sat there crying. And the social worker happened to come in. She gave me the name of a psychiatrist and a therapist to contact. And I know for a lot of us, our insurance doesn't pay for all of it. But if you talk to your social worker, it will help. I went and interviewed both of them in the same day. The psychiatrist was insane. And I sat with the therapist for 5 sessions. And on the 5th session, Wendy, we were just staring at each other smiling. And I said, I guess I'm okay. I think we're done. So that's what I want for you, is to find someone besides your family and Larry, although I know how great you are, to talk to, because it helps.
Yeah.
If you have children, or you, don't get on the internet searching for what you got. Because the first diagnosis is you got 6 months to live and you're going to die. My son did that when they diagnosed me. He called me. He said, "Mama, there's no hope for you. What do you want us to do for you?" I said, "I don't want you to do anything for me. I'm going to live." I said, "And if I don't, I'll be in a better place. So don't worry about me." So you have to really watch who you get around and what they say to you, because people can bring you down when they don't mean to. 16.
Sorry, before we get off this topic, can I also make a quick comment? I think there is no one-size-fits-all approach to this. And so, oftentimes I think, refer a patient to psychology, refer a patient to psychiatry. and that helps some people, but not everyone. I think this is, or start antidepressant. That helps some people, not everyone. There's no, again, in my practice, my experience as a physician, and frankly more so as a person, that this is something we all have to kind of trial and error and find our own answer to. And it's really hard because some of the resources are not readily available. Finding people that you trust to talk to is not the easiest thing. There's often you have to try several people, whether that's a professional or a friend, finding the right group of people who's your tribe. And it always seems like time is working against you for whatever. And it takes a lot of time. And so I think this is something that we also, let's be honest, right, in our rush medical system, this gets lost. This gets lost. That's the truth. There's not enough resources for this in the medical system. So I'm going to tell you something about me, and I apologize if this is too much information. I love lung cancer. The other thing I really love is dogs. I freaking love dogs. And so if you love animals, I think animals are another. This sounds so silly, but I truly believe in things like outside of medicine that bring you joy are so incredibly important. So whether it's dogs or cats or horses or whatever your passion is, but when the pet therapy comes through the hospital, oh my God. I may quit medicine and do pet therapy because I think it's super ridiculously impactful. Don't tell my bosses that, but yeah, they wouldn't particularly like me saying that. Maybe as a side job. Yes.
So I am on the clinical trial, but it's by Amgen, I guess. So so don't they will be the only one making that, or will other pharmaceutical people be able to make that?
So for the drug that they're making on the trial, they will have exclusive rights to that. There are other drugs like that other companies are making that will also work their way through trial. So it's a, one drug, and it has to do with kind of intellectual property rights of a specific drug. And so that will be kind of tarlatamab will be Amgen's thing for quite some time. But the principle or the kind of how that drug works, there may be similar drugs, similar mechanism of action, and there already are from other companies. They won't be called tarlatamab. They'll be called something different, but they'll have similar mechanisms by where they work. And so it won't be the only one. It will just be the first one.
Well, that's a great company. They have paid for all of medication, all the treatments. I get $30 a day on my little clinical card for lunch or whatever. I'm not in the area as far as we're outside of 50 miles, but if I was, they pay so much cents per mile. It has been, I'm talking from hospital stays, because that's part of the protocol. Every MRI, every CT scan, they pay. I don't see how any other pharmaceutical company can sit there and say, well, this one can, but we can't, because it's our lives. And not only that, they're making money off of our time, to where that should be at least take care of while you're in treatment, or the days you have to miss work. So that's something for other pharmaceutical companies I think need to look at. Should be standard across the board. Yeah.
That woman was tough. A question I was going to ask Dr. Sands, but I'm going to ask you. He was talking about screening for lung cancer. She has extrapulmonary lung cancer, which is not in the lung. They really don't have an origin of development because it was metastasized before we found it. How would they even begin to screen for that?
Okay, so good question, and very rapidly emerging field. So in case anyone didn't hear, the question is, outside of lung cancer screening, how would you screen for other cancers? And I would say right now, there's only a couple cancers that we actually can screen for, right? We can screen for breast cancer with mammography. We can screen for lung cancer with CT scans. We can screen for cervical cancer with pap smears, right? No, there is no such thing as a perfect screening test. So you try to optimize a screening test, but no screening test is perfect, right? So that's only 3 cancers really. Then, even PSA testing has sort of fallen out of favor for prostate cancer. So that's like 3.5 cancers, and there's literally hundreds of types of cancer. So how do we tackle this problem? If you're hearing this message, like the best way to treat cancer is not to get it, or if you get it, catch it early. How are we going to screen for cancers? Well, this is an unbelievably important question. And there are lots of studies now into something called multi-cancer early detection tests. So blood tests that can actually presumably test for cancers across the board early. They're only in the experimental stage right now. And so they're going to detect some cancers better than others. Like the very, very rare cancers, they probably won't be very good at detecting. The more common cancers, they'll probably be better at detecting. But big picture, it's very, very hard to detect all cancers all the time. It's going to depend on the stage of the cancer, the type of the cancer, and you need tests that are incredibly sensitive and specific. Just not there quite yet.
Lymph nodes. So couldn't people just get a CT scan like every so often and see if they have, how they see that if it's, you have to have lung cancer screening and they didn't have that?
Yeah, so the question is, could we just give everyone a CT scan and say, hey, is there something abnormal? That's a really, a very good question. And some of the challenges are, how do you operationalize that? And how many false positives would there be? Like things that are abnormal in all of our bodies that are not cancer. What would you do about it? How would you biopsy all those lesions? And what would be the detection rate? And so to date, that's just not been something that's proven to be effective. Yeah. Yes.
I didn't necessarily have a question. I just wanted to say that our company, we understand the impact that that this can have on the person and their family. So we also have a reimbursement program. Even if the patient is being treated hours away from where they live, we have a very robust reimbursement program. And I think that also speaks to a lot of us that work at the company. We've had personal experiences. My dad died when I was 11 of esophageal cancer. So I know the impact, the financial impact that it can put on a family. And I think that helps. And I agree, more pharmaceutical companies should make sure that they are investing in that area for patients. Yeah, for plus caregivers, because we know that the patient's not going to travel alone. So we also have it in place to compensate for the caregiver so that the patient doesn't have to be by themselves. So hopefully more pharmaceutical companies are going to be doing that. Yes.
Okay. I will just end by saying thank you all so much for your time today. Appreciate the questions. Please don't be shy about asking me questions, about asking other people questions, about asking your providers questions. Because once you ask one question, I think it lowers the threshold to ask more questions. And that can be incredibly, incredibly empowering. Because the worst thing is when you're feeling scared and insecure and uncertain, but you're afraid to ask. And we all get to be that way sometimes, but this is your life, as you all know, and your family members' lives, and so ask. We may not always have the answers, but we will certainly always try to get them for you. So thank you for your time today.